Kwan， 就 from Hong Kong。那我稍微介绍一下这个关教授的这个他的 CV 哦，他是毕业于这个University of Hong Kong Medical School。那他在这个香港接受完整的这些 fellow 的 training， 也到英国的 Edinburgh， 这个 Royal College of Physicians Edinburgh， 那接受这个 fellow training。那他现在的这个是担任 Associate Consultant of Department of Intensive Care New Territory West Cluster。那 Dr. Kwan 呢，他的专长是在 critical care， 那另外特别在 focus 在我们的 ECMO 跟所谓的 critical care nephrology， 所以他今天要为我们介绍这个 AKI 跟所谓的 blood purification 在 COVID-19 的 patient。那我们欢迎Dr. Kwan。
谢谢你的介绍。我的国语说的不是太好呢，我现在讲英语吧。Thank you for the invitation for delivering a talk in AKI and blood purification in COVID-19. This is the latest figure today, and in Hong Kong, so far we have nearly 11,000 cases and nearly 200 deaths. And the figure is, I take the figure today. So in fact, it really affects Hong Kong, and as you can see from the news also. What I'm going to cover today is in fact quite a lot, and I'm going to talk about the incidents over the world, the histology and pathophysiology, and also some management concerning the AKI and blood purification, and also some practical concerns the world has experienced, and also what we experienced. And in the later 10 minutes or so, we will describe the blood purification technique in the world and what we did in our center. We have some experience in sorbents, and also we also see some potential problems in during the sorbents. So first of all is the incidence. This is quite a busy slide. In fact, when you look at the figures in Wuhan, China, and also USA and Europe, you can see the incidence of AKI in USA is in fact it seems that it is much higher than that when compared to cohorts in China. And also there is quite a significant difference in proportion of cases which is put on CRRT. However, one very important to highlight in this slide and also subsequent slide, it's the, are they really the same patients? Because when you look at the percentage of ICU admission in reports and papers in China versus USA, the proportion of ICU admission are different. And more importantly, when you look at the comorbidities, the CKD mentioned here is the chronic kidney disease, HTN is hypertension, and also, in fact, the China cohorts, it's quite different from the cohorts in the USA. And in the United States, you can see there are much higher prevalence of cases who have background CKD and also hypertension when compared to those in China. So this probably accounts for the differences in the incidence of AKI and also cases which require RRT. This is another study, a meta-analysis which focused on those cases in China. You can see the incidence of AKI in all these studies varies quite a lot. And in fact, when you go back to these studies, the information of renal recovery post-discharge from ICU or from hospital and also post-discharge follow-up is quite different. So you can't see from these studies that the AKI is really a de novo AKI or AKI on top of CKD. One final point to highlight is that the policy of ICU admission in China versus Europe versus USA, it's quite different. So you can't lump the incidence of China or simplify the incidence of AKI in China versus USA. It's as simple as they are different. So you can see the picture is really complicated. Another problem is the histology and renal biopsy finding in these cases. From the reports so far, there is a wide range of pathological findings in the renal biopsies in COVID patients, including acute tubular injury, lymphocytic infiltrations, and collapsing glomerulopathy. However, one very important thing to highlight is that there are multiple range of pathological findings in the renal biopsy findings, and in fact, which this account for underlying multiple causes of AKI that exist. Some of these renal biopsy findings are post-mortem analysis, so the interpretation of the renal biopsy finding has to be very cautious. So if someone say, or if in some very early report that's hypothesize that the SARS-CoV-2 leads to a viral tropism directly affect the kidney, and this is the viral cytopathic effect. Such conclusion or relationship it's in fact not that simple. It's in fact not that simple. In fact, it is a integration of consequences of viral involvement plus or minus sepsis plus or minus multi-organ failure, which account for the high variations in renal biopsy findings. So the interpretation has to be very cautious. In fact, if you fit the renal histology finding and renal biopsy finding into this proposed pathophysiological pathway, it seems it fits, because from the clinical experience so far, what we saw is ARDS, differences in volume status, and also hypercoagulability. All these coexist in COVID patients. So we can't simply explain by a cytopathic effect. Concerning the management of COVID AKI, it's in fact, this figure is it's taken from the AKI group. There is a COVID consensus. In fact, to summarize, is that there's no specific evidence available to suggest COVID-19 AKI should be managed differently when compared to non-COVID cases. I would say from our experience, I would like to highlight a couple of things, including antibiotics, volume status, ventilator strategies, clone, and feeding. For antibiotics, in fact, we rarely start and continue with antibiotics. We check procalcitonin and CRP once every 3 days, and we stop antibiotics when the procalcitonin is normal. So most of the patients are antibiotic-free. We won't give gentamicin and almost no vancomycin. So far, we have about 60 to 70 COVID ICU cases, and we start vancomycin on only 2 cases or so. For volume status, we use Spans solution, either plasma-likes or Hartmann solution, and we intend to keep the patient relatively dry. We allow the IO balance is negative. So the urea usually came up, but we just tolerate. And we keep them in the PEEP according to the ARDS protocol. For enteral feeding and nutrition, we keep them on a 1.3 to 1.5 gram per kg per day. And for those require CRRT, we push up to 1.7 gram per kg per day. So it's quite the same as what we are doing in non-COVID patients. Concerning specific drugs, we give remdesivir, ribavirin, Kaletra, dexamethasone, and also baricitinib. In fact, the dosing is quite as labeled. I won't mention the strategies, but one point to highlight is that remdesivir is not recommended in those with GFR less than 30. And for baricitinib, if the GFR it's around 30 to 60, we reduce the dose of baricitinib to 1 milligram per day. We have started on about 20 cases on baricitinib, and the result, it seems to be quite okay. Concerning RRT, when you look at the figures, there is a high variation in the incidence in the RRT need range from 2 to 73%. So the range is very wide in worldwide figures. But when you look at the papers, there is a difference in the RRT triggers in terms of variation in studies, case series, and meta-analysis. So far, the conclusion is that there is no data to support the use of different RRT strategies than those used in the context of sepsis. There's this time, dose, and mode is similar to non-COVID-19 patients. And more importantly, so far there's no evidence that there is a clinically important cytokine removal with RRT. In our center, we have about 60 to 70 cases, and I would say it's about 10 to 15% of cases have AKI, and about 10% of cases require RRT. The practical problems we experienced is that the anticoagulation part is quite difficult, and that is why in our regional citrate anticoagulation regime, we keep our dose of citrate from 3.5 to 4 millimole per liter. And in 1 to 2 cases, they are very hypercoagulable. And on top of regional citrate, we give heparin on top. We don't have cases who are prone on RRT because we rarely prone patients who have been put on CRT, and we use ECMO rather than prone ventilation. But these are practical problems that worldwide has experienced, in particularly the USA, including all the machines has been used up, so they have to switch to either the traditional hemodialysis or SLAD. And also some of the cases has to be collaborated with the traditional renal centers, that is outside ICUs, and also the staff burnout. And also one of the technique which is already quite old from an ICU perspective, the acute PD, is coming back again in some of the centers in the US. We don't, because we have enough RRT machines, and in fact we only have 10% of cases have been put on RRT, so that is not our problem. But in fact, when you go back to the AKI work group and the consensus report, you can see they have a strategy concerning and preparation for surge in the RRT demand, including divert and triage patients, and also cooperate and coordinate the RRT response, and also train more staffs. So in fact, in some parts of the world, the RRT really have a burden concerning the outcome. The outcome, the question is whether COVID-19 associated AKI is associated with CKD or some long-term consequences. The answer is really not sure, because there is a disparate incidence and outcome across USA, Europe, and China. In some of the Chinese studies, the incidence of CKD is less reported. So, but of course, the incidence of CKD affect the outcome figures. So the answer is really, at this stage, we don't know. But there are a couple of common things which is quite sure, including AKI develops early in hospitalization, because quite a significant proportion of AKI is developing within from day 0 to day 4 of hospital admission. And also more severe the COVID, the lower chance of renal recovery and the lower remission of proteinuria and hematuria. And in critically ill cases, the more ill the cases, the higher incidence of AKI and the worse prognosis. However, the actual AKI recovery rate is still unknown. We can see from 2 studies. This is taken from Jensen, and this is a study focusing AKI in hospitalized patients in New York. There are about 4,000 cases, very high proportion of AKI, and 20% required dialysis, and half of these cases died. And more importantly, 1/3 of the discharged has AKD. So it is really quite significant. And in fact, this is the first study in the US to report the persistence of kidney dysfunctions in survivors of COVID-19 associated AKI. However, although this is a big study, but you have to be interpret with caution, because this study have not examined the temporal relationship between the development of AKI and ICU admission. And also, there's no data regarding ARDS or ICU severity score. So, and also in this study, it is unable to determine the dialysis dependence at post-discharge follow-up. So, despite the fact that the numbers are quite alarming in this study, as shown in this figure, there is quite a significant proportion, 1/3, did not have renal recovery at discharge. The study has to be interpreted with caution. However, one very interesting thing is that when you look at the trajectory of creatinine during the first 14 days of hospitalization, those who are good is good at the beginning, at the end. Those who are bad is bad at the very beginning and at the end. So it seems that it happens early, and no matter if it's good or bad, and it persists as such during the hospital stay. Another study is from China, and this is from Wuhan. Less cases. It's like quite different. Is that less than 10% fulfill the KDIGO AKI criteria, and half of the cases with AKI recovered within 3 weeks of infection. So it seems it is quite different from the US studies. However, one thing to bear in mind is again the baseline group. In this particular study, only one in 4 cases have diabetes, and only 1/3 had a hypertension. So it is it probably affects, and more importantly, 10% in these 333 cases are already on ACEI or ARB. So it significantly affects the results. In the Chinese study, the mean time of recovery is 6 days. So it's quite different from the USA studies as shown in the previous slides. So we don't know. And of course, the limitation in this particular study is that it is a single center study, and it did not check the urine COVID-19 markers, viruses, nor the markers. And out of these 22 cases, only 5 are put on CRRT. But in fact, 18 of them are critically ill. So you have to interpret this particular study in caution. In the second part of my talk, I will talk about the blood purification technique and also our experience in our hospital. So this is the potential treatment option in blood purification. Theoretically, the aim is to prevent or mitigate the organ damage, and by removing the circulatory mediators, the so-called the cytokines and also the dams. There are a couple of ways, including the hemoperfusion, absorption, plasma exchange, also, and we'll in the coming slides describe a bit. Concerning the criteria of blood purification, so far there is no consensus exists concerning its indication and also when to use. So somehow it is a no man's zone. There are a couple of techniques, and in fact we have used 3 as highlighted in the arrows here. We have tried a bit, and in the coming slides we will show you. The first 2 are the Oxiris and also the Cytosol. And both of them has been allowed by the FDA in USA concerning the emergency use in April last year. And since then, we have been using both the Oxiris and also the Cytosol. First, talk about the Oxiris. We start cases on CVVHDF, and the intent is to blunt the immune response. This is the first reported use of the Oxiris, and also this is also used in China. And all these studies show a decline in ESR, CRP, D-dimer, IL-6. In the Chinese study, improve in PF ratio, and also the MAP, and improve the Apache 2 and SOFA score. So far, the studies are at the level of case report level, and there's no randomized control trial. So the strength of evidence may not be that good, but at least we can show the our own experience. This is our own computer charting of a case, and in fact, this is of course, a COVID-19. This is the day 21 of the disease already. She has been intubated, and this is the blood pressure, and the blue is temperature, and the red is the pulse rate. This is the FiO2 and also the blood results, and this is the urine output. As you can see, there are occasions where the pulse suddenly goes up, temperature suddenly goes up, and also the airway pressure suddenly goes up. I reassure you that there is no bacterial infection or no new infection or no pulmonary embolism here. And this antibody has been positive and the CT value is already quite high. And we suspect this is some sort of a cytokine mediated response. And we put them on a Osiris filter. As you can see, once after the Osiris, you can see the pulses are coming down and the blood pressures are mitigated. Pressures are similar, but the FiO2 can tail down a bit. So we have tried on these sort of things, and in fact, it seems to work. Another episode of the same patient is that the pulses are coming down, temperature coming down, FiO2 coming down, and there's slight difference in the pressures. So it helps a bit, but the evidence, again, is not that strong. Another product is a cytosol. We put on top of a CRRT circuit or ECMO circuit. We run for 24 hours and review in 1 to 2 days. So far, our experience from the figure is that the PF ratio is improving and the VIS is coming down. We connect either with CRRT in series or with ECMO circuits. We have tried both. And in our case series, all receive enoxaparin, because as mentioned, we have a DVT prophylaxis. And on top of enoxaparin, they are all on citrate. With this blood flow, the citrate concentration is nearly 3.5 to 4 millimole per liters. And this is the target. This is a typical case of cytosol. Again, pulse suddenly coming up, temperature suddenly coming up, no bacterial infection. And we put them on already day 8, antibody positive, already on dexamethasone. And with the cytosol, the fever and pulses seem to be stabilized. And also in this particular patient, he can be extubated. So we somehow regard this sort of event as a cytokine storm because we can't quantify, and we usually empirically put them up. And these episodes tide over afterwards. So clinically, it seems to be working. And what we check is the CRP and also and also the procalcitonin. Of course, as mentioned, there's no bacterial infection, but it seems that clinically they improve. And this is our experience from February to September last year. We have 40 cases on COVID-19 in this particular time point. Out of these 40 cases, 5 died, and our 30-day survival as a whole is 34 out of 40 survived. Out of all these cases, we put 10 cases on cytosol, and also 9 on high cutoff filter, and 2 on a Osiris filter. One of them required ECMO. ICU length of stay 18 days, duration of mechanical ventilation 15 days. So far, we noticed that concerning this particular product, it's that it improved in PF ratio, but it will not affect the PaCO2 or VIS. Of course, there are some other products in the world, including some products in China and also Japan, and their case reports reported there is improvement in EAA, the endotoxin, procalcitonin, the interleukins or so. However, there is no consensus on when to start, how long should we treat, when to stop, and why the treatment is stopped. There is much variations in all these case reports. So if you ask me whether this sort of purification product is good or bad, we don't know because the mechanisms they exert their benefit is poorly understood. We are not sure whether such a reduction of excessive inflammation is good or bad. We don't know. And also reduction of all these mediators, okay, but whether it is really have a clinical impact, we are not sure. And also, at which particular time point will they be useful? We don't know. As shown in our cases, one of the cases is started on day 21, and also another cases we put them on day 8. So far we have no idea. The final point are, although they have an FDA approval, but the approval is somehow an emergency basis. So whether the ground is solid is doubtful, because these are bench performance. And also, from the case reports, they can't reach a hard endpoint, that is the mortality. The final thing we observe in our center, in some and also some other centers, is that the doctors have the urge to do something, or at least help in the view of COVID, even if it may not be useful or sometimes useless. But in fact, it seems that it is the doctor's urge to help patients, so they put on something. But we are not sure whether this is really helpful. So this is what I'm trying to say. And if there's any question, be free to ask. And this is my email. So anyone, if it is interested in this topic, so be free to ask me. And that's the end of my talk. Thank you.
Thank you. Thank you, Dr. Kwan, for his excellent speech. So is there any question from our audience? So may I ask you a question? You have mentioned
Yes.
that the removal of the mediator or cytokine may be beneficial for the patient, but sometimes we cannot know, we do not know when and how. So do you think that we monitor the cytokine, the major cytokine, to as an indicator for initiate or stop the like a hemoperfusion or removal of the mediator?
Yes, what we available is to monitor CRP, D-dimer, and also interleukin 6. And when we go back to our own series, we find that the indicator, there is a variation in the indicators. The IL-6 is coming down, the CRP remains the same, and the procalcitonin remain to be normal. So, and we try to analyze our series, and also we go back to the literature and also other case reports. There is much variation. And also another important point is that the level of all these markers they did not correlate well with the clinical findings. So the markers may be coming down, and it varies, but the clinical finding is different, and the correlation is it's quite weak, I would say. So although we check all the indicators, but it does not reflect well the clinical scenario.
Okay, so is there any question? So the COVID-19 can attack like lung and the kidney because they have like ACE2 receptor. So do you, from your clinical experience, do you observe like lung injury and kidney injury is go together, or there's some discrepancy, or which organ is the we can observe when like kidney injuries? You mean that kidney injury can be present 0 to 4 days? So how is the relation to the lung injury?
Okay, so far in our experience, we only have 15% of cases have acute kidney injury, and they present quite early at the very beginning. That is, once they're admitted to the ICU with an AKI, they have an AKI. We rarely have cases who are started off with normal renal function and then develop AKI late in the disease. So I suspect those, and of course those cases who have AKI, they have they most of them have a diabetes and also hypertension. So I suspect the AKI, it somehow happen on top of those who have a comorbidities. It's probably more prone to have an AKI. I don't think fluid balances or the anticoagulation takes a major role in the development of AKI. And this is what we observed. So in the later part of our experience, once we notice that the patient is old with hypertension and also diabetes, we are very cautious at the very beginning. Initially, we dry up most of the patients, but once in later course, in I would say in recent 2 to 3 months or so, once we see all the cases, we drop our dry size strategy and keep them euvolemic. So this is the experience to share.
Okay. Is there any other question? If no, we thanks Dr. Kwan
Okay, thank
for
you.
your speech.
Okay, thank you.